antibiotics in the contains the beta-lactam ring in its structures. So the two groups is concerned the beta-lactam antibiotics or the penicillin, and second it is the cephalosporins. So what are the mechanism of action of this beta-lactams are? So it inhibits the cell wall synthesis by inhibiting the transpeptidases. So it will inhibit the cell wall synthesis by inhibiting the transpeptidases. So what is the function of the transpeptidases? It will cause us a transpeptidases is responsible for cross linkage of elongated peptide chain. So it will cause us a cross linkage of the elongated peptide chain. So as the transpeptidases is inhibited, so cross linkage of the elongated peptide chain won't occur. That is, transpeptidases is helpful for the strengthening. That's how the cell wall synthesis is inhibited. And other mechanism of action is penicillin will binds to the penicillin binding protein and inhibit the cell wall synthesis. So any of the mutations in the penicillin binding protein will lead to the resistance. Is responsible for the development of the resistance. So transpeptidases. So it is the last step. It inhibits the last step of cell wall synthesis. Next we have this Staphylococcus aureus, which is resistant to methicillin. So why it is a methicillin resistance? That is MRSA. Methicillin resistant Staphylococcus aureus, it is resistant to methicillin because of it has the alteration in the protein binding, penicillin binding protein. So in this situation, the drug of choice is the vancomycin. Vancomycin, it is a glycopeptide group. It belongs to the glycopeptide group. Remember, if Staphylococcus aureus is resistant to penicillin, if it is resistant to penicillin, it will resistant to all beta-lactams except the fifth generation cephalosporins. Next, Alexander Fleming is the first one who discovered this penicillin. He discovered the penicillin G. So this penicillin G drawbacks are: 1. It is acid labile, narrow spectrum, and third, it is having the resistance, and it have short duration of action. Short action is present. So the acid resistant penicillins or oral penicillins are mnemonic is ODCA, V for penicillin V, A for oxacillin, D for dicloxacillin, C for cloxacillin, A for ampicillin, and amoxicillin. So main thing about this amoxicillin and ampicillin is it will cause a side effect of diarrhea. So it is seen more with ampicillin than amoxicillin because of incomplete absorption in small intestine. So it will enter the large intestine, it will irritate the bowel. That's why it causes the diarrhea. And second thing, so they are used in neonatal meningitis, which is caused by the listeria. We have to give the IV ampicillin is given along with the gentamicin. In the penicillin allergy patients, we have to give the cotrimoxazole. It is a combination of the trimethoprim plus sulfamethoxazole. And third, a patient came with the sore throat. On examination, tonsils are inflamed and inflamed and enlarged, and you treated with aminopenicillins, that is amoxicillin or ampicillin. We asked him to take ampicillin for 500 mg thrice daily for 5 days and come review after 5 days. So after 3 days of treatment, the patient came with skin rash, complaining of skin rash. The diagnosis is infectious mononucleases. So this aminopenicillins, therefore aminopenicillins should be contraindicated in patients with infectious mononucleases. Next, fourth one, it is OCP with ampicillin. Have some drug interactions with OCPs. So OCP consists of the estrogen and progesterone. Estrogen will undergo the enterohepatic cycle. So it will have the long duration of action. Because it is undergoing the enterohepatic circulation. Whereas the ampicillin it is a broad spectrum antibiotic. So as it is a broad spectrum antibiotic, it will alter the gut flora. Because of altering the gut flora, it will affect the enterohepatic cycle. Therefore, it will cause a decreased duration of action of OCPs. Ampicillin will cause a decreased duration of action of the OCPs. So bacteria will release as an enzyme called as penicillinase, and it will break down this penicillin. So this penicillin won't work. So we are having this penicillinase resistant penicillin. Those are first cloxacillin, O for oxacillin, nafcillin, dicloxacillin, fifth it is methicillin. So oxacillin side effect, it is hepatitis, nafcillin neutropenia, methicillin will cause us the interstitial nephritis. So bacteria also releases other enzyme called as betalactams. It will break the betalactam. So these betalactams won't work. So we have discovered the betalactamase inhibitors. We have other group of drugs known as betalactamase inhibitors. That is VCAT is the mnemonic. V for Weber-Bactam, C for clavulanic acid, A for Avibactam, T for tozobactam, and S for sulbactam. So these beta-lactamase inhibitors alone don't has this antibiotic property. So they should be combined with the beta-lactams to prevent the resistance. So what are the beta-lactams? These beta-lactams are added in the fixed dose combinations. So Weber-Bactam is added with meropenem, clavulanic acid with amoxicillin, and Avibactam with meropenem, and tazobactam with penicillin, and sulbactam with ampicillin should be added in the fixed dose combination. What is fixed dose combination? The drugs are combined these two drugs should have the same volume of distribution or the same T half. The drugs which are used in making this fixed dose combinations should have same volume of distribution or the same T halves. Other thing, we have this augmentin, which is a trade name of fixed dose combinations, or amoxicillin plus clavulanic acid. And the other group we are having the extended spectrum penicillins. One, we are having this aminopenicillin. 2, carboxypenicillin. In third group, it is of uridopenicillin. The drugs examples of the aminopenicillins are ampicillin and amoxicillin. Examples of the carboxypenicillins are carbonicillin and ticarcillin. So what is the side effect of the carboxylicin? It will cause us the bleeding. So where we use these carboxypenicillins are Pseudomonas infection. Next, uridopenicillin we have that is meslocillin, azlocillin, piperacillin. So these uridopenicillins are the most extended group of penicillin. So these are used in uridopenicillins are used in both Pseudomonas and also the Klebsiella. We are using both for Pseudomonas and also the Klebsiella. Next, what are the uses of penicillin? Mnemonic is BLAST, PRR. B for Bacillus anthrax. L for leptospirosis is used in leptospirosis. A for actinomycosis. And S for syphilis. Syphilis is caused by Trypanosoma pallidum. When we use this penicillin in treatment for the syphilis, it will release as the toxin, and this will have the adverse drug reaction of the Jarisch Hexheimer reaction. The treatment is give mild sedatives and mild aspirin. So T for the tetanus and P for Pasteurella multocide and R for rat bite fever, R for rheumatic fever prophylaxis. What we use in rheumatic fever prophylaxis? We use as this benzathine, penicillin, which is long acting, given as a once in a month or once in 21 days injection. Next, the drugs which are useful in the leptospira. Leptospirosis. 1. It is of mild, moderate to severe leptospirosis. In the mild leptospirosis, we use this doxycycline, ampicillin and amoxicillin. Whereas moderate to severe, we have to use as the injection, that is IV penicillin and ceftriaxone and cefotoxin. Next, doxycycline. Next, all the penicillin, route of excretion of all penicillin is by the kidney, by tubular secretion. We are having one drug known as probenicide. Will inhibit this tubular secretion and increases the duration of action of penicillin. Other group of betalactams are second group, that is cephalosporins. In the cephalosporins, we are having the 5 generations of cephalosporins are present. So these will inhibit the mechanism of action by inhibiting the cell wall synthesis. And so first generation, it is mainly acts on the gram positive. As the generation increases, second, third, fourth and fifth, as the generation is increasing, so broad spectrum activity will increases. So first generation, we have parental and the oral. So in the parental, we are having this cefazolin. In oral, we have cephalexin and cefadroxil. Cefazolin, it is used for the surgical prophylaxis. It is used for the surgical prophylaxis. Next generation is the second generation. In the second generation also we have the oral and also the parental drugs. Oral drugs are cefaclor, cefuroxime, axitin. In parental, examples are the cefuroxime and cefoxitin and cefotitine. So first and second generation drugs won't crosses the blood-brain barrier. These won't crosses the blood-brain barrier except the cefuroxime. So these are high in CSF. So used for treatment of the bacterial meningitis. And cefotitine and cefoxitin. So these both are used in anaerobes, used for treatment of the anaerobes, that is Bacteroides fragilis. So actually the drug of choice for the anaerobes is metronidazole, then the clindamycin. Next group, it is the third generation. In third generation also we are having the parental drugs and oral drugs. So parental drugs examples are the cefoxitin, cefotoxin, ceftriaxone, cefoperazone and ceftazidime and ceftriaxone. And oral group of drugs examples are cefixime, cefdinir, ceftibuten and cefpodoxime. So the third generation cephalosporins which produces the disulfiram reactions are the cefoperazone, and the third generation cephalosporins which causes the neutropenia and the thrombocytopenia are the ceftazidime. So gonorrhea, which is an STD. So drug of choice for gonorrhea is injection. Ceftriaxone should be given 250 mg IM single dose, or intramuscular spectinomycin in 40 mg per kg dose should be given, or we have to use the azithromycin or doxy for 1 week. Next, typhoid fever. In the typhoid fever, drug of choice for typhoid fever is injection ceftriaxone, or we can use the cefotaxime. For the oral, we are having this cefixime is used for treatment of the typhoid fever. Next, carrier. For carrier, we have to use the ciprofloxacin. Next, the cephalosporins which contains the methyl thiotetrazole group are cefamandole, cefotitine, cefoperazone. So So all these drugs can increases the prothrombin time and increases the bleeding, increases the risk of bleeding. So if we use the warfarin, the patient who is using the warfarin also increases the prothrombin time. So if we use the warfarin along with these 3 drugs, it will lead to warfarin toxicity. Next, 4th generation cephalosporins all are injectables. So one is cefepime, next cefpyrone, and third one is cephalidim. Next, 5th generation. These are also injectables. We are having the 2 drugs, that is ceftobiprole and ceftaroline. These are injectable. These are used in methicillin resistant staph aureus and also in the community acquired pneumonia. Other drug which is a newer drug is the cefiderocol, which is a newer drug which is used in complicated UTIs. Cefiderocol. Next group is atypical betalactams. We are having the 2 examples for this, carbapenems group and monobactams groups. So first it is the carbapenem. All will ends with penams only, penams, that is imipenem, meropenem, ertapenem, doripenem, ferropenems. All will ends with penams only. So these carbapenems will act against the gram positive, gram negative and also the anaerobes. This imipenem will also act against gram positive, gram negatives and also the anaerobes. It is a broad spectrum antibiotic, but only side effect, only drawback, it is a short acting. So why it is short acting? Because it undergo metabolism by the dehydropeptidase 1. So this dehydropeptidase 1 will metabolize this imipenem. So in order to prolong the duration of action of this imipenem, we have to use as a dehydropeptidase inhibitor along with the imipenem. So this imipenem is used with cilastatin, which is dehydropeptidase inhibitor. So what are the side effects? Side effects of this is adverse drug reaction is it will causes the seizures. So be careful. So imipenem also route of elimination is by the kidney. So be careful while using in the renal patients and also in the epileptic patients. So other group of atypical beta-lactams are the monobactams. So in the monobactams we are having the only one example, that is aztreonam. So aztreonam, so these monobact, many of the beta-lactams which is allergic to the amoxicillin, that is beta-lactams. So he will be allergic to all the beta-lactams except this aztreonam. So this is known as the cross-reactivity or cross antigenicity. So this aztreonam have no cross reactivity or cross antigenicity with all beta-lactams except ceftazidime. Except this ceftazidime, it have no cross reactivity with other beta-lactams. So what is the more? This aztreonam is only used for the aerobic gram negative infections. That's it.